All right, here we go. Chapter 17, neurologic emergencies. We're going to talk about, obviously, the brain, because the brain is the nerve center. So some of the things we'll talk about are going to be stroke, seizure, altered mental status. We're going to talk about presentation. We'll talk about how to sort of figure out even more definition to our patient's mental status in general. But let's talk about some things here. The elephant in the room. Stroke is the fifth leading cause of death and disability in the United States. It's common in geriatric patients. It's becoming more and more common in now some of our younger patients. There's really just about anything and anything that we can talk about that's sort of leading that to happen. The contributing factors to stroke, all those risk factors we talk about, those are going to start piling up into significant cardiovascular disease as our patient starts rattling off things that are wrong with them and conditions that they have and some things that they do. There are intrinsic and extrinsic causes of stroke. Intrinsic are the things that we can't change. You can't change your family history. You can't change the fact that certain portions of our population are more likely to have a stroke than others. We can change the fact that we eat kind of a crummy diet and spend too much time sitting on the couch and smoke too much and drink too much, too much eat, drink, and be merry. And we start having later in life some problems like stroke and hypertension and coronary artery disease that just sort of start piling themselves up and make these things like what we've talked about, stroke, coronary artery disease, myocardial infarction, hypertension, any of the respiratory conditions we've mentioned, more and more likely. The treatments that are available for stroke, though, holy smokes. I don't know if anybody got a chance to look at the Tavuti website and some of the video I had up for cardiovascular emergencies. There's actually a video that's great. They're actually doing a cardiac catheterization, and you watch them go in with the guide wire and bust up that clot and get it out of there, and then put the stent in and open that artery back up so that blood flow is now possible. And you can actually now watch the blood travel through those hypoperfused areas of the heart. You watch the artery fill up and deliver that oxygenated blood flow. Well, that's in the heart, a heart attack. The American Heart Association used to refer to stroke as a brain attack because it's much the same mechanism. And they are now actually doing that same type of therapy for stroke. They are going in with a wire, doing a catheterization, cleaning out that clot, breaking it up and vacuuming it back out so that it doesn't go further down and cause more problem, and then opening those arteries back up and now reperfusing the brain. Some other altered mental status things we'll talk about, like I said, are seizures. Seizure is a common emergency we get called for. Most of the time, it is not a new thing for this patient or their loved one. So a lot of the times when we get sent out for a seizure call, it's because something new, fun, and exciting and different is happening to this poor patient. And we'll talk about some of the causes and some of the wheres and what fors and how we're going to treat. Sometimes alterations to our mental status has no real definitive defined thing that we can put our finger on to say, yes, this is what caused that. So a lot of times we spend a good amount of our assessment ruling in and ruling out different causes. So things like hypoglycemia. We take a patient's blood sugar. We can say, is this patient's blood sugar high or low? That's why I told you any person with an altered mental status gets a blood sugar. Because if our patient is altered and we check a blood sugar and the blood sugar is regular, we can say right then and there, okay, cool, blood sugar is not the problem here. Even a device that I hate with a passion, a pulse oximeter. If we think hypoxia based on our patient's respiratory rate, rhythm, and quality could be the problem and cause for their altered mental status, we can check and see what is this patient's oxygen saturation. If I look and that number is well below the 95, 96 that we hope to see, well, I can say, oh, hypoxia could be part of the problem here. And we'll get into some of the common causes and some of the common things that will cause this altered mental status, because a wealth of our calls are for the altered patient. Let's get into some anatomy here. The brain is the body's computer. The brain is the motherboard that runs this whole thing we call a body. Controls breathing, speech, all other body functions, both high and low. So the nerve impulses we talk about for heartbeat, the neural impulses we think about when we talk muscle contraction to pick things up and put them down, they all originate in the brain. The brain has three major parts: the brain stem, the cerebellum, and the cerebrum. The cerebrum is the largest part of the brain. It makes up most of the brain tissue. The brain stem is arguably the most important part. Does anybody remember why I've been saying that? Do you remember from the respiratory chapter where all of our breathing and really sort of mandatory to sustain life controls live in the brain?
Is it the brain? The brain stem like basically controls everything.
Yeah, the brain stem controls all the important stuff. The brain stem is the part where our respiratory center lives, our respiratory drive lives, our respiratory rate, rhythm, and quality lives. And the same for the C in our primary assessment. Our circulatory rate, rhythm, and quality all live in the brain stem. The brain stem is also the only part of our brain that actually exits the skull. It leaves the skull through the foramen magnum. It's a sharp little hole in the base of the skull that connects the brain stem and the brain itself to the spinal cord. The spinal cord is another part of our central nervous system, and its job is to carry all those nerve impulses, all the messages that are generated by our computer down to the business end, down to where things actually happen. When we talk things like stroke, and we'll even mention it in trauma a little bit when we talk head injury, we can see times where there has been so much built up intracranial pressure. Remember, it's a closed vault, and the only opening is in the bottom. So that buildup in pressure can actually start to cause some brainstem herniation, is what it's called. And that's really the brainstem and other parts and portions of the brain being forced out through that foramen magnum, through that sharp hole, like Play-Doh spaghetti. Brainstem herniation is generally one of the last things we see before somebody goes into cardiac arrest from increased intracranial pressure. And it's really just the brain being mushed out, like when you squeeze the toothpaste from the middle. Here we have a pretty good diagram of all that. You see the cerebrum. Cerebrum is the largest part of the brain. And we have that tiny little cerebellum right behind it, which we'll get into in just a couple of minutes. So, brainstem, all the basic functions. Brainstem controls really all the important stuff. The cerebellum controls our ability to be sort of a normally functioning human. The cerebellum controls muscle coordination, our ability to move, our ability to stand upright and not just constantly lose our balance and tip over. The cerebellum really allows us to accomplish the characteristics of being a person. The brain stem allows us to accomplish the work of being a human. So we have messages being sent by the brain, and this is what they're sent through. There are 12 cranial nerves. So these are cranial nerves that actually don't really, I guess we'll say, attach to the spinal cord. These cranial nerves leave right at the base of the skull and come out and innervate the head and the face, There are 12 pairs of them. They're numbered 1 through 12, one for each side of the face. And what I am going to tell you is, thank God we're not responsible for learning those. Because when you go on to be a paramedic, you'll have to memorize them and know exactly where they go and exactly what they do, period. Like rote memorization. Just know that there are 12 cranial nerves. We'll be fine. After that, we have our spinal nerves. Those spinal nerves actually exit from the brain down into the spinal column, and we have two nerves that branch off the spinal cord in each direction, one to the left, one to the right. Those spinal nerves actually now carry that message further. So the brain sends the message to the spinal cord. The spinal cord is like the neural highway. It's the pathway for everything to get out. And if we didn't have these spinal nerves, the message would just stay in our central nervous system. It would stay in the brain, it would stay in the spinal cord, and it would never get out to realize its action potential. These spinal nerves leave the spinal cord, leave the spinal column, and go out and innervate other spots of the body. So I already broached this topic just a little bit. Many different disorders can cause brain dysfunction. We know of a couple already. Why don't you guys tell me what one or two of them are?
Hypoglycemia.
Hypoglycemia, absolutely. Think of some things that might affect the brain's ability to carry out its mission. It's two more hypo things that I'm thinking of right off the top of my head.
Hypotension.
So hypotension, sure, hypotension is going to lead to hypoperfusion of the brain tissue once our blood pressure falls low enough, because there's not going to be enough pressure in our system to supply that oxygenated blood that the brain needs. So yeah, hypotension, hypoperfusion, and then there's one more. Think all the way back to the respiratory lecture 2 whole days ago.
One was like like low blood, like losing, I forget, hypo.
So yeah, hypovolemia
Yes.
will lead to that hypotension.
Okay.
Look a little bit further down on this slide and tell me some of the things that the brain needs in order to accomplish its task.
Is hypoxia?
Bingo.
Hypothermia.
Hypoxia, we'll go with hypothermia. We can just continue to rattle on anything that may affect the brain's ability to accomplish its mission. So we've talked hypotension, we've talked hypoperfusion, hypoxia, hypoglycemia. The beat goes on and on and on. We could go all day figuring out things that are going to have an effect on the brain. So really anything that can cause an alteration in the brain's ability to create that energy, to take oxygen and take glucose, turn it into adenosine triphosphate through aerobic metabolism, and remove those waste products, is going to alter our patient's mental status, period, end of time. Because the brain is the only spot in our body that will not switch over to anaerobic metabolism. That's why with our hypotension patient, sometimes they'll complain of sudden loss of consciousness. Well, that's an altered mental status. Our hypoperfusion patient, our shock patient, doesn't matter the reason they're in shock, but what's some of the signs and symptoms we look for in shock? Now, I'm not talking vital signs, just something that we can get just from talking to this person. Changes in their what?
Mental status.
Yeah, mental status. Even slight alterations in a shock patient's mental status prove to me without shadow of a doubt that this patient is not only in shock, but is probably getting worse, because I'm watching their mental status start to dip because their brain is hypooxygenated. So now I'm starting to think hypoxia, keep them warm, oxygenate them, lay them down, and get them to definitive care. So we're going to cruise through some of these because arguably a lot of the times we don't get called for just your average everyday run-of-the-mill headache. We don't a lot of times get called for migraines. Not that people don't go to the emergency room for them, but more often than not, people who get severe significant headache or tension headaches or migraines, they are aware of and familiar with this condition. More often than not, they are either treated at their general practitioner's office, at a specialist's office, or someone drives them to the emergency room. Headache can be a symptom, however, of other neurologic conditions. When we talk the two different kinds of stroke, one specific sign or one specific symptom will point us towards, yes, my patient's having a stroke, and yes, this stroke is likely to be a doozy. But only a small percentage of headaches are caused by a serious medical condition. So if we wind up getting sent out for a patient whose chief complaint is headache, the onus is still on us to dot all our I's, cross all our T's, and make sure we have looked at our patient and gathered our history and gone through all of these things that may cause their altered mental status and may cause their headache and their neurological problem to make sure we're not staring down the barrel of something particularly negative. We'll move from normal headache to something a bit more aggressive, something a bit more uncomfortable. Tension headaches generally caused by muscle contractions in the neck and around the head. Normally very attributable to stress. This is not something where if we just remove the stressor from this patient that they're going to feel instantly better. Tension headaches generally are just bad, nasty for your patient to have to deal with. It feels like their head's in a vice, and more often than not, time heals this. Do we sometimes get called for this? Absolutely. Are we expecting super wonky increased vital signs and airway, breathing, and circulation issues and skin color, temperature, and condition issues? What do you think? Do you think something like this causes a huge alteration in our patient's ability to be a person and is likely to cause their demise between when you get to them and when you get them to the emergency room?
No.
Yeah, so what we're looking for here is our general impression of our patient. Our patient's chief complaint will start to point us in the direction we want to take with our assessment. You know, we see a patient who is clearly uncomfortable, rubbing their temples because it feels like their head is being squashed, and they're maintaining their own airway. Their breathing rate, rhythm, and quality is good. There's no increased effort. There's no noise. There's no pain associated with their breathing. Their circulatory status, well, we'll probably have a little bit of a rapid, strong pulse because they're in pain. We'll probably have some good skin color, temperature, and condition because they are still perfused, they are still oxygenating and respirating. So that's pretty much going well. And when we ask our patient our OPQRST questions, they're probably going to relate to us some form of stressful event or large-scale stressor that they have been under. And we can start working through the rest of our assessment and figuring out, do I have a sick patient? Do I not have a sick patient? Because even though it looks like a tension headache, it could still be a stroke. We won't know that until they get to the hospital and they get some images taken. We're still going to monitor our patients' ABCs. We are still going to provide them high flow O2 with 15 liters per minute by non-rebreather mask. We are still going to reassess them as if they were having a stroke, because we're going to evaluate and treat based on a worst case scenario. We don't just show up and the patient's complaining of a headache and I go, all right, come on, get in the ambulance. We'll take you in and have that headache evaluated. And we're off on our merry way. The same can be said for migraines. Migraines is, again, we're getting now to the next level because tension headaches tend to eventually go away. Migraines can last for hours and days. Generally, they do have some associated nausea and vomiting and some visual changes and some sensitivity to light and sensitivity to sound and just misery for our patient. Generally described, the quality of this pain is throbbing or pounding or pulsating. Work it up the same as anybody else. And last but not least, we have sinus headaches. Anybody who's ever had a sinus infection is very much familiar with this. It is fluid accumulated in the sinuses. It just continues to build up. It is very tender to the touch. It is very spot-specific pain to where we know we have sinus cavities in our skull, and that fluid has no ability to actually get out. It is trapped in those sinus cavities. And this is a lot of times a pressure. Another thing you can ask your patient, and this is kind of a weird question, but I learned this from a doc. You ask them if their teeth hurt when they walk. And if they say yes, generally that's leading us to some pretty increased sinus pressure. And that can be a very significant root cause of your patient's discomfort. So now let's talk when a headache becomes a bit more of a concern for us. So let's take a look at this table on the right. It's in your book, but we're going to go through it. Sudden onset of symptoms. Really, almost any time your patient reports to you that I was sitting there minding my own business and it felt like I was hitting the head with a shovel and now my head's killing me. It felt all of a sudden like there was an elephant sitting on my chest. I was sitting at the kitchen table reading the newspaper and all of a sudden I couldn't breathe. Think about what that actually means happened in the body. The body was just clicking along, business as usual, having no big deal. And then bingo, all of a sudden something bothered them enough instantaneously that the first thing they thought of was to pick up the telephone and call 911. So, sudden onset of our headache, an explosive thunderclap of pain. This is that whole hitting the head with a shovel analogy. Headache associated with an altered mental status. A patient over the age of 50. Somebody explain that to me. Why a patient over the age of 50? Why is that increased caution for concern?
Because they're older and their brain might not be able to handle it as good as someone under 50.
Okay, age is a significant factor in a lot of things. And age all by itself sometimes can be a precipitating factor to some of this, and it can be cause for concern. And then you start thinking about changes in our patient's vasculature over time, changes in our patient's heartbeat and heart rate, and just general wellness over time. And you have a patient over the age of 50 who has a sudden onset of excruciating head pain, you start going, all right, well, these are the things now we're expecting. This is starting to sound like our patient could be having a stroke. For one reason or another, if our patient has a depressed immune system, so they're on maybe chemotherapy meds for a cancer they're being treated for, if they're on some sorts of biological meds or even steroids, will depress your immune system some so that people with like autoimmune diseases and such won't have their immune system attacking healthy cells. Neurologic deficits. So neurologic deficits really encompass that whole last 2 bullet points: changes in vision, one-sided paralysis, difficulty speaking, difficulty with balance. We'll get into that very, very deeply here in a second because we'll start talking about stroke. Next, we have neck stiffness and pain and fever. We're looking for actually infectious disease at this point because those are 2 hallmark signs of meningitis. Whether it's viral or bacterial doesn't really make any difference to us. Neck stiffness and pain and fever up to and including loss of consciousness and significant alteration to mental status and death are some pretty characteristic signs of meningitis. Some other thing we start thinking about with some of these concerning signs and symptoms could be brain tumors that have finally gotten large to the point where now they are causing some neurologic deficit, or sudden onset of symptoms because the tumor wasn't so big before. One of the big ones we're going to talk about now is stroke. Stroke, like I said, used to be called brain attack. It can also be called a cerebrovascular accident. That means for one reason or another, the vasculature in our cerebrum or in our brain had an oops. Could be a clot, could be a hemorrhage. It is book definition, interruption of blood flow to any area within the brain. So when we talked myocardial infarction, heart attack, we had a clot in one of those cerebral coronary arteries, blocking off blood flow to the tissues of the heart. With our brain, we have the brain being hypoperfused for one reason or another, clot or bleed, and it's going to cause some issues. Those issues, if not corrected, will result in complete loss of brain function in that area, because much like a myocardial infarction, if we have a piece of brain tissue that now infarcts because it's hypoperfused, that means it's dead, and that means it is no longer going to work for its written cause, and that is to generate nerve impulses and send messages off through the central nervous system, out through those spinal nerves, and cause an action. About 80% of strokes are ischemic. Ischemic strokes are the better one to have, believe it or not. An ischemic stroke is what I was just describing. We have a blockage in a cerebral artery. How bad the stroke is depends on where the blockage is. If it's in a much smaller vessel, deeper in the brain tissue, well, it's not going to affect as much brain tissue. You'll see a picture here in just a minute of a larger sized clot in a larger cerebral artery causing a much bigger problem. Strokes will result from thrombosis or embolus. Fancy word to say clot. They can range from no symptoms at all, so your patient really may have very non-specific, really not much complaint in the world, to complete and total neurologic deficit. Now, who's been to the doctors recently? Or maybe not even recently, but who's been to the doctors?
Hopefully everybody.
Yeah, right? You see that sign on the wall that says fast? Or you've seen the commercial on TV that says that, talks about recognizing the signs of a stroke, and they use the mnemonic FAST, right?
Mm-hmm.
That, believe it or not, for the most part, is the stroke scale you guys are going to use in the field. You're going to do that same exact test, and we'll talk about it when you guys get here today. We'll talk about it a little bit later in this lecture as well. But that is how we are going to assess a patient for a stroke, because we are looking at pretty much everywhere of the body to try and figure out what is going on with this patient, and is it likely that they are having a stroke? Because they only have to get one part of that whole stroke assessment wrong. They only have to fail one of those tests, and we would call in a stroke alert to the emergency room. When we got on the radio, we would tell them that our patient did not pass the stroke scale. The more of those things that they can't get right, the more likely it is that the patient is actually having a stroke. So here's the picture I promised. If you look right here, we have our blood clot. I have it highlighted on the screen. That blood clot is in a pretty large cerebral artery, and it is blocking off a pretty large amount of brain tissue. If that clot got stuck right here instead of all that brain tissue being affected, we would have this area here being affected, as opposed to this whole bit on our patient's brain. Does this picture make sense to you guys?
Yeah.
So remember, 80% of strokes are this kind. 80% of strokes are ischemic, and these are the ones that can be corrected. They can go and give us some clot busting medication in the emergency room. They can go in with the wire and rotor out that clot and make things all better. And a lot of the times, once they reperfuse that brain tissue, it was only ischemic. So if it was only ischemic, that means it's still alive. So when they reperfuse that ischemic area, our patients will actually sometimes get better. And some of the signs and symptoms and things that we see with a stroke will actually begin to go away. And our patient will improve with some treatment and some rehab after they've been drawn out of the woods of this stroke. On the other hand, we have hemorrhagic strokes. Hemorrhagic strokes account for really only about 13% of strokes, but this is where an aneurysm of some sort forms on that cerebral artery. Now, when we talked aortic aneurysms yesterday, what happens when an aortic aneurysm lets go? Come on, folks.
Something constricts. I could be wrong.
So we have that bubble forming on the outside of the artery, right? And that arterial tissue is going to start to weaken and get thin the bigger that bubble gets. And then sooner or later, that bubble pops. What's no longer intact when that bubble pops?
The artery.
The artery itself. So in our image here, we have an artery that has sprung a leak, and it has leaked that blood into our patient's cranium. It's leaking directly into the brain. And leaking into the brain like that means all of that blood is not going to where it's supposed to. All of that blood is just sitting now, free floating inside of our patient's brain tissue. And that's not the way that blood was meant to be stored. That's not where that was meant to be, because that is not going to help our patient's cerebral arteries oxygenate the tissues of the blood. That blood is just out there making a mess. So if this bleed is large and significant enough, we'll actually see some of the more negative things I was talking about earlier, with increased intracranial pressure and maybe some alterations to my patient's respiratory rate, rhythm, and quality. That's because now the brainstem is under attack and it's being compressed. We may actually on images see, almost like with a tension pneumothorax, that the brain will actually start to shift to one side, because there is so much blood taking up so much space and compressing so much brain tissue that the brain itself as an organ is wholly being squozed to the other side of our patient's skull. Hemorrhagic strokes are much more negative just based on their mechanism. Hemorrhagic strokes, they don't have the ability to go in and reperfuse that tissue. They don't really have the ability to do much other than hope that stroke doesn't get worse. This is going to cause some pretty defined signs and symptoms. We have the worst headache of my life. So your patient who's having more likely having a hemorrhagic stroke than an ischemic stroke, what do you think the onset of their pain is going to be? How do you think they're going to describe that?
Pounding.
So it could be pounding, but let's think onset for a minute. We'll get to quality, I promise. How's this pain going to start? So we've done our scene size up, we've done our primary assessment, we've made our transport decision, we're starting our secondary assessment. And I asked my patient, so can you tell me how all this began? Do you think it's likely that that aneurysm was up there causing them the worst headache of their life for months on end?
Could be, yeah. Why not?
Or do you think it's more likely that that aneurysm was up there living all by itself, living its best life, bubbling out on that cerebral artery, and then it popped, and when the pressure started to go up, that's when the patient had the worst headache of their life?
Yeah.
Yeah, aneurysms can live in people's brains forever and a day until they don't. And that's when they pop, and that's when we have hemorrhagic strokes. It's normally a rapid onset with no provocation, no palliation of the worst headache of my life. That's how they describe the quality. That's how they describe the severity. And a lot of the times, those are the symptoms we hear with someone who's having a hemorrhagic stroke. Our patient who's having an ischemic stroke doesn't really have any pain complaints, doesn't normally have any really like symptom that they're going to tell you about. They just start to have that neurologic dysfunction, and that neurologic dysfunction is going to present itself outwardly in them flunking that stroke assessment we were talking about. So we got some pretty negative stuff there, but now let's talk about something that's a little bit better. And I say only a little bit better. When a patient has stroke-like symptoms that improve without treatment all on their own in less than 24 hours, that's what we will call a transient ischemic attack. These used to be referred to as mini strokes, or I forget what the other dumb thing we used to call them was. But it is just that. It's transient. It goes away. No treatment, no nothing, no lasting deficit. Everything gets better. What it is, though, is a warning sign that a much larger stroke is on the horizon. About a third of patients who have a TIA will have a stroke. Also, anyone who's having stroke-like symptoms should be evaluated in the emergency room by a physician, because we don't know if those problems are going to go away over the next 24 hours. And even if they started getting better since the patient called 911, that doesn't mean that this is not a stroke. That just means that clot could be on the move. So patients exhibiting stroke-like symptoms, there is 3 pages of all this stuff. Holy smokes. Facial drooping. So that's that F in the FAST exam that I mentioned. We have our patient smile, and we're looking at their ability to keep their face symmetrical. If your patient smiles and one side of their face goes up and then the other side of their face frowns or looks like it's sort of sloughing off and running away, well, they have failed the F portion of our FAST test. Or if they have any sudden weakness or numbness in the face, arm, leg, or one side of the body. Remember, each hemisphere of your brain controls one side of your patient's body. So if my patient is having a stroke on the right side, the left side of their body may be flaccid completely, may be weak or numb, or they may have no ability to even sense that entire side of their body. They may have no ability to move that entire side of their body. The lack of muscle coordination is known as ataxia. We can also see some loss of balance because the brain is responsible for keeping us balanced and keeping us upright. And we can have some vision problems. These are all what we were referring to when we talked neurologic deficits to go along with a headache. So sudden blindness, sudden blurred vision, sudden double vision, sudden difficulty seeing, difficulty swallowing, altered mental status, problems with their speech, difficulty expressing thoughts or use the right words. So this is a patient who, when they go to talk to you, they may say a word that makes absolutely no sense. And you will see the look on their face get all furrowed up and wrinkled up and mad because in their brain, that's not the word that they said. They said the right word, but heard the wrong one come out, and they're getting mad about it. If you can think of how frustrating that must be. We'll start to have some slurred speech, possibly some sudden or severe headache. Next, we have some confusion, dizziness, weakness, more alteration to their mental status, tongue deviation, and coma. So if you're out there taking notes, if you've written down the word fast, write the letters BE. So we want to be fast. We're not just going to look at the stuff I'm going to describe to you as the fast scale in just a minute. We want to be fast. So B stands for balance. Any new onset of a balance issue or inability to hold themselves upright, well, that's a negative on the stroke scale. That means they did not pass. The E in B fast stands for eyes. Any new trouble with their eyes, anything at all, is going to be a significant finding on the stroke scale. That means they didn't pass that test. The F, well, we already talked a little bit about the F. That is facial droop or facial muscle control, really. When we have our patient smile and one side does nothing or kind of just mushes away, well, that is a significant finding on our stroke scale. Next, we have arms. We are looking for arm drift when we measure our patients in the stroke scale. So what we have them do is take their arms, put them out in front of them, thumbs pointed away, palms pointed up, and close their eyes. We have them close their eyes for a very specific reason. If your body can see itself doing things that aren't right, it will stimulate other portions of the brain to take over and fix that problem. If our patient is having a stroke and they are losing the ability to control their arms, but they have their eyes closed, their brain and their eyes don't play that game. So with their arms closed and their palms, with their eyes closed and their arms pointed up, that arm will slowly drift and rotate right back down to their side and wind up next to them because it's not under conscious control anymore. So they're not actually sort of cheating the system there. The S is speech. So we want to give them a tongue twister to say. The sky is blue in Boston. She sells seashells down by the seashore. Someone who's having a stroke is most likely not going to be able to stumble their way through that. And then last but not least is an important little deviation from the way we're going to look at this to the way lay people look at this, the T. The T, when you see this on your wall in the doctor's office, stands for time to call 911. Well, welcome to the party. You guys are 911. So the T for us means time last known well. Ischemic strokes can generally be reversed up to about 4 hours out. So if our patient's time last known well was less than 4 hours ago, the hospitals around here actually will be able to provide some treatment and hopefully provide some rehabilitation, and hopefully our patient gets a little bit better. If our time last known well was outside of that 4-hour window, we're still going to do all of our same things, but the hospital might not be able to do what they want to do to treat this stroke. It is very, very important to your patient's downstream continuing care to find out when was the last time somebody saw Nana acting like Nana and not acting like this, because that may mean the difference between Nana being able to be reperfused and have some decent quality of life downstream, because a lot of times the problem with stroke isn't always our patient has a stroke and just dies. A lot of what happens with this stroke and the damage that it does to the brain is our patient has a stroke and then never returns back to their normal self anymore, because the brain has suffered such an insult that it's no longer able to function up to its expected level anymore. Our patient winds up maybe bed confined or unable to care for themselves, or having to live in a nursing facility for the rest of their lives. Maybe they are completely unable to talk. Maybe they aren't able to feed themselves. We need to make sure we get a good handle on when was the last time this patient was seen well. Go through your stroke assessment and do all of the things that I just outlined and get this patient transported to the closest appropriate facility. Now, the area that we live in, we are lucky, 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 because I looked not too long ago, and to the best of my knowledge, every hospital in the entire state of Massachusetts was actually able to provide at least the beginnings of stroke care. They were able to take the images and look at the pictures and diagnose the stroke and begin some of the clot busting medicines, begin some of the more advanced treatments, or get the patient transferred to somewhere that could. So I couldn't find one that didn't have at least 24-hour CT and an emergency room, which is really what we're looking for, because they can't give those clot busting medicines to someone who's having a hemorrhagic stroke. If we give a medicine that goes into our bloodstream and breaks up every single clot that is in our bloodstream to someone who is having a hemorrhagic stroke, we just made their stroke worse. But if they give clot busting medicine to someone whose stroke is caused by a blood clot, their stroke is likely to get better. Now let's get into seizures. Seizures are a neurological episode caused by a surge of electrical activity in the brain. What a seizure is chaotic electrical emergency in the brain. The brain is very good at processing information and sending out information. That's what its job is. It's been doing it forever. So when a patient has a seizure, instead of sending out those nice regimented, regular, normal messages to the body to tell me to pick up my thermos and have a drink because my caffeine level's getting a little low, the brain sends off mass quantities of chaotic, unrecognizable, unreadable messages to the whole rest of the body. And what do you think the body does when the brain does that?
Tries to overcompensate.
It just overacts. It doesn't even try to overcompensate, because there's no compensation to be had. The brain is gone all cattywampus, and the nerve impulses are just continuing to fire off. So what happens is our patient really loses all ability to control any of their muscle function, loses all ability to control any of their body function. And when we see a grand mal seizure, we have a patient who is on the floor because they've lost the ability to stand, twitching and muscle contracting and spasming all over the place because their brain is sending off these messages that just are uninterpretable. The body has no ability to override what the brain is doing, so it's just doing what the brain is telling it with all of that crazy electrical activity shooting off, and there is no compensation because there's no ability to. They say about 2 to 3 million people in the United States have epilepsy. Epilepsy is one of the biggest contributors to a seizure. Most of the time, like I said, people with a seizure condition at least know they have this condition, and they are fairly well versed in it. Patients who have tonic-clonic seizures, these are these abnormal discharges leaving the brain. They are normally in large volume from both hemispheres, and the body is just under insult from the brain. This is characterized by unconsciousness, generalized and severe twitching. These problems or seizures or whatever you want to call them, you'll hear them called all sorts of things. He's having another episode. Okay. They normally last under 5 minutes, we hope. Generally, they last for a few minutes. Then our patient becomes what we call postictal. That postictal stage is the following of the seizure. It's the end of it. The seizure ends. The brain starts working normally again. The body starts booting back up, and our patient slowly starts to regain what their normal level of consciousness is. We also have something called status epilepticus. Status epilepticus is when those seizures do not last for just those couple of minutes. They do not go away. They do not have that period of getting better and starting to wake up. Those seizures continue and continue and continue, and may last for 5 or more minutes, up to 30 minutes. And what I can tell you is with these seizures, if your brain is not sending off the appropriate messages to tell your body to do what it is supposed to, what are you probably not doing very well?
Refusing.
Perfusing. Because when people are seizing and all of these chaotic messages are going out and all of this just whole scale muscle contraction is happening, your patient's not breathing. So hypoxia is going to be a problem with our seizure patients. Hypoglycemia with all that muscle contraction may be a significant problem with your seizure patient. They are pretty sick, especially if they get to the point of status epilepticus and not breathing for longer than 5 minutes, or 3 seizures in a row without any lucid period. The body is just wearing itself out and wiping itself out, and it's only going to be able to do that for so long. So this is going to be an altered patient. So one of our vital signs for this patient has to be checking a blood sugar, because hypoglycemia can actually cause your patient to have a seizure. There are some other causes of seizure, not just hypoglycemia. We have congenital issues, so things that patients have inherited. We have structural issues in the brain from things like tumors, infection, scar tissue, head trauma, stroke. We can have metabolic issues, things like hypoxia or weird blood values, hypoglycemia, poisoning, overdose. Febrile seizures are generally seen in kids. Children can have just these ridiculous, rocking, god-awful fevers that the temperature that they can spike would near kill an adult, but they can maintain it. Kids will have a febrile seizure when their temperature goes from normal to 104 in 5 minutes. If their temperature just goes up gradually because they've been sick for a little while, they do fairly well with that. if a patient who's pediatric is seizing, but went from perfectly normal 1 minute to could cook an egg on them the next, that's when we see a febrile seizure. So if you're going to start thinking febrile seizure with your pediatric patient, make sure you have a skin color, temperature, and condition on them, because that will tell you, all right, my patient's not hot, so what can't this be? Now we start to rule things in, rule things out. You get your skin color, temperature, condition on your seizing pediatric patient, and their skin temperature is normal. It does not feel like they were just pulled from a sauna.
It's not a febrile then.
Yeah, it's not a febrile seizure. So then next on my list of things to rule in, rule out would be hypoxia, hypoglycemia, because I can do both of those things very quickly, very easily. More skin color, temperature, condition, a 10-second finger stick, and a check of my patient's capillary refill and some SpO2, just to make sure that I am dotting all my I's and crossing all my T's. I want to look at and check the things that I know that I can check and run them right to ground, because I can start figuring out, okay, well, even though I don't know what caused this seizure, because we may get there and a neurologist might not know what caused this seizure, but I would like to cross off the things that I know that it isn't. So why is all this important? Well, we want to know, is this any different from any of the patient's other seizure conditions? Like I said, most of the time, this is not the first one. If it is the first one, expect everybody on scene to be absolutely terrified and completely horrified, because it's not pretty to watch. Start thinking other things. What else could this be if this is a patient's first seizure? If this is a patient who's got a lengthy seizure history and the family reports that they take seizure meds every day and they are compliant with their meds and they never miss and they always go to their doctor's appointments, start thinking like, all right, what else could be going on here? This isn't the old days. We're not worried about patients, swallowing their tongues and we have to put something in their airway. The patient is just going to seize. There's nothing you're going to do to affect any change on that. So make your peace with that. There's not going to be a change to their seizure until their brain stops, losing its stuff. So we are going to make sure that this patient does not further injure themselves, is what our real hope is. Because a lot of times people are standing when their seizure begins. People wind up in very inopportune spots when their seizure begins. So we just want to make sure that we don't allow them to seize themselves down a flight of stairs. We want to make sure that we don't allow them to, knock things off the wall or off of tables to hurt them even worse. Just keep your patient safe, because once they start waking up and they get into that postictal stage, we will have some time to apply some oxygen, support their ventilation, make sure their airway is open, clear, and secure, check their pulse rate, rhythm, quality. We will be able to start to get some history as that postictal stage progresses a little bit and they start to wake up and return to their normal mental status. We'll be able to check a blood sugar. We'll be able to do all of the things that we want to do. We just have to make sure that this seizure doesn't cause this patient any further injury. If they had all of that wholesale muscle contraction going on and they weren't breathing, expect to need to provide to them some additional oxygen. Have that ready to go. And once your patient starts waking up, begin providing that to them. It's really just going to be make sure this patient doesn't get any hurt any worse than they already are when you got there. what is going on? All right, there we go. And one of the last things we're going to talk about here this morning on our neurological is the Glasgow Coma Scale. Now, I am going to do my best to send this to you. This is in your book, Chapter 17, Table 6. The registry loves to ask questions about what a patient's Glasgow Coma Scale would be. What I can tell you is the chair that you're sitting at in your house right now has a Glasgow Coma Scale of 3 because your chair has no eye-opening response, no verbal response, and no motor response to what's going on around it. So your chair has a 3, your computer has a 3, your desk has a 3. But let's talk about some of the other stuff. Your patient's eye-opening response, verbal response, and motor response. That's what we're measuring here. This gives us a little bit more insight into my patient's mental status and brain function and level of consciousness. If my patient's eye opening is just spontaneous and regular like it's supposed to be, they blink when they're supposed to blink, they look around, we give them a 4. When I'm speaking to my patient and assessing their level of consciousness, and they're talking to me and the things that they're saying to me make sense, and they're oriented to person, place, time, and event, well, I give them a 5 for their verbal response. If I ask my patient to touch the tip of their nose and they do it, or I ask my patient to, when I introduce myself and I go reach out to shake my patient's hands, I'm subtly giving a command here. If they reach out and shake my hand, well, their best motor response is a 6. Patients who are doing all of these things appropriately have a Glasgow Coma Scale of 15. And then you start working through the lists if my patient isn't doing all those things appropriately. So Bob, when I have to yell at him to get him to open his eyes, now instead of spontaneous eye opening, Bob is response to speech. So Bob gets a 3 on his Glasgow Coma Scale. If Bob is disoriented and not conscious, alert, and oriented times 4 and answering my questions appropriately, well, now instead of a 5, he gets a 4. And so on and so forth through the list. These are things you're just going to have to remember, and remember how the Glasgow Coma Scale works. Generally, the bottom of the picture there, 13 to 15. 13 could indicate some mild dysfunction, but who knows, not really. 15 is somebody with absolutely no neurologic deficit whatsoever. Someone with a score of 9 to 12 is really going to be sort of middle of the road. We're starting to see some brain dysfunction. We're starting to see some neuro deficit. And then anybody below the score of 9, so anybody 8 or below, is pretty significantly and severely altered. And these are the people who we're probably maintaining an airway on and maybe supporting some ventilation on, because their neurologic function is now so low that the body and the brain aren't really on the same page anymore, and they're not really able to do the things that they need to do in order to be functional as a human being. We are now working on Chapter 19, Endocrine Emergencies. The big one we're going to talk about, the main one we're going to talk about, is diabetes. Now, diabetes comes in a couple of different flavors. I am a type 1 diabetic. That means my pancreas does not work at all. We will get into what that means in just a minute. Type 2 diabetics, they have some similar but different problems. Type 2 diabetic, their pancreas still works. It's just either not working quite as effectively as it needs to. Maybe they are taking in too many calories and their pancreas can't keep up with the workload. Or sometimes when people get old, they tend to outlive the functional life of their pancreas. So it's just not able to shoulder the same amount of task as it used to. The problem with diabetes is twofold. Glucose. What's glucose's job in our body?
To give the cells energy.
Yep. Glucose is used in energy creation for the cells. It is the primary fuel source that the body uses to make energy. What happens, and this is on the left, our normal healthy patient, and on our right, our diabetic patient. So with our normal person, they eat some food. The food gets down into the stomach, digestion begins. That food is broken down in the intestine into simple sugars. Those simple sugars get out into the bloodstream through the intestines, and insulin will be released from the pancreas.
None of my screens have changed.
Oh, because I didn't click all the buttons. Here we go. Should be better now. Insulin is released from the pancreas, and insulin is the key that opens up the cell so that the glucose molecule can get in. Glucose itself is a very large molecule. Those simple sugars that leach out into our bloodstream through our intestines is a large molecule. And without an adequate supply of insulin, that sugar never gets into the cell. The cell wall does not get opened up, and when that doesn't happen, the cell doesn't get the sugar it needs to create energy. And if the cell doesn't get the sugar it needs to create energy, it's going to metabolize energy a different way. So this is the other side of how aerobic metabolism can turn into anaerobic metabolism. So we have not enough oxygen and glucose being delivered in a adequate supply, and the cells go, well, we're going to go ahead and create some energy, but that energy is going to make a whole soup of byproduct. It's going to make a whole lot of acid, and it's going to make our patient worse. Not to mention, when we look over at this right picture now and we see what happens with a diabetic patient that eats, they eat the food, that's the same. Digestion begins in the stomach, also the same. That food gets broken down into those simple sugars. All right, all this is functioning business as usual. That sugar gets out into the bloodstream, and either little or no insulin is produced and released by the pancreas. So that cell wall doesn't get opened up, that glucose doesn't get into the cell, energy is not created, and we have all of this sugar just floating around. All of that excess sugar that floats around in our patient's bloodstream, remember, it's a large molecule, just goes off and damages some of the smaller, more delicate vasculature in, say, the eyes or the kidneys, and really anywhere else it can go to cause a problem, it does. But then this problem perpetuates itself because the cells think that they are starved of sugar because there's not enough insulin to let that sugar into the cell. So the cells are down there saying, hey, we're starving, feed us. So that message gets to the brain, and the brain triggers hunger and tells us we need to feed ourselves. So we feed ourselves, and food is eaten, digestion begins, and food is broken down into simple sugars, and those simple sugars leach out into the bloodstream through the small intestine, and little or no insulin is produced or released. So the blood sugar continues to go up, and the cells continue to think that they're starving. So this is just a self-perpetuating negative cycle that is going to continue to get worse and worse and worse and worse and worse. Type 1 diabetes is treated with insulin injections. So what will happen is the food will be eaten, the digestion begins, the food gets broken down into simple sugars, those simple sugars enter out into the bloodstream, and this manufactured insulin that our type 1 diabetic patient is taking allows that glucose now to get into the cell, and the cells can create the energy they need and make ATP and not create all those extra waste products, and everything clicks along business as usual. So one of the key things in metabolism and energy creation and sugar use is the body's ability to adequately supply this insulin so that the channels that allow that glucose into the cell can open and get that sugar in so that energy can be created and the process works the way that it's supposed to. When there is extra sugar in the body, it is stored in the liver. The liver will actually store, and the liver and the fat will store sugar deposits. And it's for times when the patient actually might be starving or doesn't have the ability to eat. Generally, our body will sense when the blood sugar drops below 70, and it will trigger the liver to convert this glucagon that has been stored and make glucose. Our body has the ability to make the sugar it needs for a very short period of time. So when that happens, a patient's blood sugar will actually, without eating, go up a little bit. But that doesn't last for long. It is just another one of those compensatory mechanisms for the body to actually keep itself functioning. What really needs to happen is when your blood sugar begins to dip, you need to have something to eat. You need to put actual sugar into your system so that your blood sugar will maintain itself at what is a normal level. We will get into normal blood sugar levels here in just a moment, I promise. So normal metabolism and glucose regulation. We eat that meal. That meal produces those sugars, and those sugars go into our blood system, into our bloodstream, and our blood glucose level goes up. This is no matter what. This is every patient, every person. You eat, the sugar goes into your blood glucose level goes up. That blood glucose level going from 60, 70, 80 to 120, 140 is what actually stimulates your normal healthy person to release some insulin so that the sugar that's necessary can get into the cells, and the cells can go on about their business and create their energy and do their thing. And then the rest of that sugar that's available and extra gets uptaken. It gets converted into glycogen in the liver, and those glycogen stores are what produce that glucagon through some really significant processes when blood sugar goes back down. So we've eaten, we've used up that sugar, we've stored the extra sugar. Now our blood sugar starts to go down again. Our blood sugar will go down to around 70, and at 70, that glucagon is secreted from the liver, and blood sugar goes back up. Our patient is able to maintain. Patient is going to have a normal mental status. They're going to have a normal reading on our blood glucose meter, so it won't be under 70. They won't be symptomatic. And then eventually they eat a meal, and the circle goes round again. Their blood sugar goes up, insulin secreted, cells get the sugar that they need, liver takes up the rest. Eventually they start getting hungry, blood sugar goes back down. Glucagon is secreted from the liver to maintain a normal blood sugar level. That blood sugar level goes back up to what will be considered normal, so above 70. And eventually my patient eats again, and things work along swimmingly. The part of this that doesn't work with a diabetic is at the 3 o'clock position. So my diabetic patient, they eat their meal, their blood sugar goes up. If they're not maintaining their diabetes appropriately and monitoring their blood sugars and such, their body's not going to take care of that. The body's not going to secrete that insulin. The cells are never going to get that sugar. The blood sugar is never going to get a chance to go back down below 70 because I didn't do anything to make my blood sugar regulate itself. So I won't have any necessity to secrete glucagon. My blood sugar is just going to go up. And then at some point, I'm going to get hungry and eat another meal, and my blood sugar goes up another step. And then this all repeats, and my blood sugar goes up another step and just keeps getting higher. The longer I go, without taking my medication appropriately. We have the ability to figure out the wheres and what fors of all that's going on. Now, hyperglycemia technically is a blood glucose level persistently higher than 120. Generally, with hypo, so low blood sugar, it's typically a blood glucose of 60 or less. When we get much below 60, we start to see a pretty significantly ill patient. But what's our protocol? When are we going to start treating a patient's blood sugar?
If we see that their mental state is altered.
Okay, so that's definitely part of it. So a patient is altered. We have symptomatic. This is telling me that there is something wrong. But then there's one other thing, one other box I have to check. It's on your screen right now.
Glucose meters.
Yeah, their blood sugar has to be below 70 and symptomatic. So generally, we don't get telephone calls from people's family members for their diabetes when, they're having a blood sugar normal day. So there was a symptom somewhere. It's just on us to make sure that we are checking and dotting our I's and crossing our T's and figuring out what makes this patient symptomatic. Hypoglycemia and hyperglycemia really have a lot of the same signs and symptoms, with one very, very profound exception. So think back to that circle slide that I just had up there. My diabetic patient eats, their blood sugar goes up, insulin isn't secreted, cells don't get to make the energy they want, they're triggered again to think that they're hungry, so they eat something, and blood sugar goes up. Maybe it goes up a little, maybe it goes up a lot. That's kind of immaterial at the moment. And then that process just continues to repeat. Does that sound like it happens rapidly, or does that sound like it might take a little bit of time to develop? Remember, just about every time you put something in your mouth, it takes at least a half hour, 45 minutes for it to break down.
Takes a little time.
Yeah, it takes some time. So hyperglycemia is generally a patient who complains of our signs and symptoms of a diabetic emergency, which we're coming to because we're going to skip this because we have already done glucose monitoring. So our patients' complaints for diabetes, what do you think they might be?
Excessive thirst.
Excessive thirst. That's going to be both hyper and hypoglycemia a lot of the times. What else?
Go in the bathroom a lot. A lot of urination.
Okay, so yeah, a lot of excessive urination. So that's most of the time our hyperglycemia patient, because all of that extra sugar has to go somewhere. It doesn't just continue to float around and float around and float around. So it will eventually start to be excreted from the body in urine. But remember that sugar molecule is really big, and it's going to draw water into the kidneys and the urinary system. So our patient who's got hyperglycemia may be pretty profoundly dehydrated or hypovolemic. So we could start to see some signs and symptoms of shock. What are some other things we could be on the lookout for?
Diaphoresis.
Diaphoresis, yeah, they're likely to be sweating profusely. Keep going because you guys are getting it. Somebody else this time, though. Come on, there's other people out there. I know it.
Um,
What one group of tissues in particular needs sugar, has to have it, won't use anything else?
The tissue,
How about the tissues of the brain? Will the brain tissues actually use anything else to metabolize energy?
No.
No. So we'll have an altered mental status because our patient's blood sugar is either so high or so low that the brain isn't getting the sugar that it needs, so that it's getting a bit cranky and it's not really doing the things that we want it to do because it's not able to, because, well, it doesn't have any sugar. So here are our hallmarks of a patient whose blood sugar is really high. And this is a blood sugar of greater than 350 milligrams per deciliter of sugar in their blood. We have polyuria, which means they're peeing a lot. We have polyphagia, which means they're hungry. We have polydipsia, which means they are excessively thirsty. This is the sort of hallmark symptoms of a patient in DKA, diabetic ketoacidosis. Their blood has become so sugary that it is also becoming acidic. And that acidic nature of their blood is actually making all of these problems worse. We'll have some nausea and vomiting. They may have peed out so much fluid that they are pretty profoundly dehydrated, and we'll see some changes to their mucosal membrane. We may see some very rapid, deep respirations or Kussmaul's breathing. When we smell this patient, we will actually have a fruity odor to their breath or to their person just leaking from them. This is a patient whose blood sugar is generally pretty profoundly high, but we've already talked about high blood sugar, and high blood sugar doesn't get there quickly. High blood sugar takes some time to develop and build up. So our onset for these patients is going to be slow. It's going to be, I haven't felt well for a day, 2 days. It's going to be a patient who is complaining of general malaise and not being able to get out of the bathroom and constantly being hungry and constantly being thirsty. And that's what we're looking at for signs and symptoms. So the delayed onset of diabetic-like signs and symptoms is going to be what we're looking for with a high blood sugar. Now let's talk about low blood sugar. Do you think low blood sugar has a rapid onset or a delayed, sort of protracted onset? Do you think it takes a long time or it's shorter?
Delayed?
All right, explain that to me.
Well, because it's lower, so the body's functioning slower with everything going on.
All right, I just wanted to see where your head was at. Because if we're watching blood sugar go up in steps, right? So it doesn't just go from 70 to 942 in the course of one meal. But I'm sitting here right now, and if I wanted to, I could take insulin, and in 20 minutes, I could have my blood sugar in the 40s, and I would be sitting here, instead of talking to you guys, I'd be barking like a chicken because I haven't eaten any breakfast yet. And I just took a huge bolus of insulin to prove my point because, well, I'm not very bright. So low blood sugar is going to come with a lot of the same signs and symptoms. It's going to come with a lot of the same problems, really, except for that polyuria, polydipsia, polyphagia. But low blood sugar will actually also stimulate an epinephrine release in the body. So I'm likely to be tachycardic. I'm likely to feel thirsty and the need to sort of energize my body because there's no energy there, even though I have all that epinephrine. I'm likely to have an altered mental status. But my diabetic patient who has a hypoglycemic event going on, they're actually going to become hypoglycemic more rapid. The changes to your patient's condition aren't protracted and drawn out. The changes to your hypoglycemic patient are generally pretty sudden. And once we give them our treatment for their hypoglycemia, which as long as they are conscious and alert and able to maintain their own airway, that oral glucose, after we verify a blood sugar of below 70 and symptomatic, our adult gets a tube of oral glucose. They're going to start to be able to explain to us why their blood sugar went low. Oh man, I took my insulin before I left the house, and I ran to Dunkin' Donuts, and I didn't realize I had left my wallet at home, so I couldn't buy any breakfast. So I've injected myself with insulin, but I haven't fueled myself with anything that's going to make sugar. Are you seeing the progression? Are you seeing the way that this all works?
Yeah, that makes more sense.
Yeah. Hypoglycemia generally has a much shorter onset just because of the real mechanism of what's going on. It is more, hypoglycemia is worse for your diabetic patient in the short term. So hypoglycemia can cause your patient to be unresponsive or dead right now. Hyperglycemia, with that syrupy consistency it adds to the blood and having all those huge extra glucose molecules in there floating around, is worse for your patient over time, because those extra sugar molecules floating there with nothing to do but go around and play ping pong and wrecks those things with more buildup. And the longer it goes on, the worse the sort of after effects of being a diabetic can become. We cannot treat in the field hyperglycemia. Our hyperglycemia patient needs to be closely monitored on an insulin drip through an IV, really in an intensive care unit. Insulin is a very dangerous drug. It is very sort of narrow, the dosing windows about between what is safe to give someone and what will cause them to be hypoglycemic and unresponsive and dead in short order. So what do you guys think our normal blood glucose range probably is? If we start treating at 70, is it pretty safe to say that it's between 70 and something else? Because
70 and 30.
yeah, I'll take that. Every book says something different. Some will say between 70 and 110. Some will say between 70 and 120. I am an insulin dependent diabetic, and if I can keep my blood sugar around 130, like Paul just said, all day, every day, I would be a happy camper. Because if you haven't noticed just yet, this is a bit of just an absolute bonkers crazy balancing act, wouldn't you say? You know, how much insulin do I take? How much food can I eat? Is this going to be too much? Is this going to be not enough? How do I know? I don't really.
What kind of foods?
What kind of things can I eat and have this not be a day where I'm trying to chase my blood sugar for the rest of the afternoon? It's a pain. And that's why a lot of diabetics turn out to be non-compliant with their care plans and their medication, because it just becomes like all-consuming and just absolutely infuriating. So sometimes our diabetic patients aren't exactly the best patients in the world because, well, it becomes a bit of a pain in the neck. So what is our emergency care for our diabetic patients? Here we go. It's fairly straightforward. It's pretty simple. It's a huge concept, but our care is pretty simple. We monitor ABCs and treat the problems with those for anyone. We provide supplemental O2, 15 liters per minute by non-rebreather mask. We're going to support their respirations because if they've been sick enough for long enough and their diabetes is, if their blood sugar has gotten to a point where their blood has become so acidic they've become toxic, or their sugar is just so high that internal organs are being damaged just by that alone, not to mention the hypoperfusion and the anaerobic metabolism, sooner or later, we're going to have to ventilate these people. So providing O2 and supporting their respirations is going to be a bit of a big deal. And we determine their blood glucose. Now, diabetic ketoacidosis is a blood sugar of above 350. There's other hyperglycemic problems like hyperosmotic, I can never say this word. It is, I have to read it slowly. Hyperosmolar non-ketotic syndrome. This is a patient whose blood sugar, when we check it with our machine, rather than getting a number, we're probably just going to get the two letters HI. That means, depending on the manufacturer of your glucose monitor, your patient's blood sugar is either over 500 or over 600. There's no way for us to figure out any higher than that because once you start getting up over 500 or 600 as far as a glucose goes, you need to draw actual lab work to figure out what the number actually is. It's not uncommon for people who don't know that they're diabetic or are becoming newly diagnosed to be completely unresponsive with a blood sugar of 700, 800, 900, 1,000 or more and barely survive because their blood is actually killing them. They have become so toxic and so heavy with sugar that there is no way for any normal body process to actually take place. So we have our signs and symptoms, we have our treatments, and we have the one medication we can use for a patient who we find diabetic and symptomatic with a blood sugar below 70 milligrams per deciliter of blood. Gone are the days where, I think I mentioned this to a couple of you guys, and I said that, when I first got my EMT certification, that if we had a diabetic patient who was altered, we just gave them sugar. We weren't allowed to check blood glucose levels because that was considered an advanced skill. So we figured, well, if their blood sugar's low, this will help them. If their blood sugar is already that high, probably not going to hurt them. Well, we were wrong. Now they took a page out of the common sense book because, we can teach 4-year-olds down at the Jocelyn Clinic or at Floating or at Children's Hospital how to check their blood glucose. So we can probably teach certified medical professionals how to check a blood glucose in the back of the ambulance and not call that an advanced level skill. You guys have the ability to both evaluate and treat this medical condition. We're looking, again, with our hypoglycemia patient for a sudden onset of altered mental status. Both hyper and hypoglycemia patients may present as almost looking intoxicated or altered like they're having a stroke. We're most likely to see cool, moist skin in our hypoglycemia patient because of that epinephrine release. We're likely to see warm, dry skin in our hyperglycemia patient because of the polyuria. They're peeing away all their extra fluid. We may see seizure type activity in either patient. We may see anxiousness, restlessness, combativeness in either patient, because the brain at the end of all of this, whether it is hyperglycemia or hypoglycemia, the brain is not getting the sugar that it needs to accomplish its job, because there's all this, it's like water everywhere, not a drop to drink. The cells are surrounded by this sugar, but can't use any of it in a patient who's got hyperglycemia, because insulin's not being produced and the insulin is not letting that sugar into the cells. And if sugar can't get into the cells, they're going to say, hey, we're starving down here. And the body's going to say, all right, we'll fix that. We're going to feed ourselves. And then the blood sugar goes up. And then this progressive thing happens over time where the blood sugar goes up in steps, until sooner or later, our patient becomes ill and starts to exhibit some of the signs and symptoms we've talked about today. So, do you guys have any questions about diabetes? Diabetes is an easy one most of the time for people, just based on the fact that more and more people now are becoming diabetic. We have a huge surge in people having diabetes as a medical condition, whether it's type 1 or type 2, and really whatever it comes down to for us, our assessment and evaluation and treatment are all going to be pretty close to the same, because we can only treat hypoglycemia. We can't treat hyperglycemia. We can use our glucometer as a tool to figure out whether it is hypo or hyperglycemia that we're dealing with. We can use our assessment to make sure that all these things are matching together. And then we transport, we monitor the ABCs, we make sure that we recheck our patient's blood glucose every 5 minutes as a vital sign. And if we treated it, great. We make sure that that sugar that we gave for our hypoglycemia patient is making their blood sugar go up. We make sure they're maintaining a mental status. They're not starting to have seizure activity. They're not becoming unresponsive. They're maintaining their own airway. They're breathing appropriately. They're circulating blood appropriately, and they are remaining perfused. And we just work everything right back to primary assessment, general impression, airway, breathing, circulation, making sure that the treatments we provided were being effective. And from there, we transport. We've done all that we can. We can't fix hyperglycemia. So
We can't, but paramedics can, right?
So sort of. The solution to pollution is dilution. What a paramedic will do with a patient who's got a really, really high blood sugar is pour a bunch of fluid into them, because they're watering down now. They're adding volume. So they're spreading some of that sugar out to try and get the blood sugar to come, the actual blood sugar number to come down some. That works for a little bit. And depending on how sick this patient's high blood sugar is making them will depend on whether giving them extra fluid is actually even indicated. Really what they need is IV insulin through a pump, because that insulin will now slowly bring their blood sugar back down to earth in a more reasonable level, which will sustain them a whole lot better than just kind of pumping a bunch of fluid into them. But paramedics, yes, they can affect a little bit of a change with a patient's blood sugar being too high. We're buying time at that point when they do it.
Okay. I wasn't sure if, like, with med control direction, they could actually administer it. I didn't know if they carried it or not.
No, you know what? MedFlight doesn't even carry or start insulin in the field. Paramedics can transport insulin running through a pump, but they cannot and will not initiate insulin therapy. Don't even let your patient use their own insulin when you arrive on scene, because a lot of the times there's something else going on with what the patient has sort of going on with them. It's not normally such a simple problem of, well, I was just non-compliant with my meds and I ate like a jerk and now my blood sugar's 600 and I don't know what to do. A lot of the times there's an underlying problem with a patient whose blood sugar has gotten that high. And even someone whose blood sugar has been profoundly low, you know, sometimes it can be explained pretty simply. Other times, I mean, last night, I'll talk about this right now. Last night, I had dinner, regular dinner. I took my normal insulin bolus for it through my pump. And 45 minutes later, my glucose monitor is screeching at me because my blood sugar is low. Still to this very minute, I have absolutely no idea why my blood sugar went low half an hour after I ate a pretty decent sized meal, biggest one of the day. But it did, because really diabetes is a disease that sort of just does whatever the hell it wants. A lot of times there is no rhyme or reason. Sometimes things make sense, but a lot of times they surely do not. All right, I'm going to put you guys on another 10-minute break, and we are going to get the behavioral emergencies lecture in. And by the time we finish that, it will be time to come in for some skills and some facilitated discussion and working on the stuff that everybody seems to enjoy a whole lot more than lecturing. So I'll see you guys back here in 10.
All right, thank you.
Yep. It turned into an EMS problem, and it turned into a police and prison problem. This is not something that is really being managed, I don't think, altogether that well. And much with like a lot of the stuff we can talk about in healthcare, follow the almighty dollar and you'll figure out why this is becoming such a large scale problem. What we need to do is figure out how we can best evaluate, treat, and assist a patient who is having a behavioral emergency. So we can skip over some of these goals and objectives, and we'll get right down to brass tacks. So let's take a look at our scenarios here. First call, 45-year-old male at work, PCA at a nursing home, tells his boss he has been depressed for 2 weeks, has been thinking about killing himself, history of depression, no meds times 10 years. Second call, 21-year-old male at home standing in the front yard with police wearing only pants and sneakers. Mother called police after she was threatened by her son. Excuse me. He said that he was going to kill her and burn the house down. Third call, nothing big to report here. Commercial fire alarm, doing a standby. Fourth call, called to the Latham School for children with behavioral issues for a 16-year-old female who had wandered into the middle of Route 6A in an attempt to harm herself. On arrival, staff told her she wandered into traffic after unsuccessfully banging her head several times against a plexiglass window. So, what is it about these that constitutes a behavioral emergency? How do we even decide what is a behavioral emergency?
Anything that appears out of the norm for a normal, rational person?
Absolutely. Behavior is the manner in which a person responds and interacts with their environment. They're just general everyday actions. A behavioral emergency is when that behavior now is atypical. It has become unacceptable and intolerable by family or community standards, or when the patient is a threat to themselves or others. Any reaction or interaction with their behavior that interferes with their person or their activities of daily living is going to be a behavioral emergency. A lot of this stuff follows under the altered mental status category. So in that, we just talked neurological lectures. If a lot of our behavioral emergencies fall under the altered mental status catch-all, what does that mean for us? Think of some of the things that can cause altered mental status and might mimic other conditions.
Hypoglycemia.
All right, hypoglycemia, hypoxia, hypoperfusion. We have trauma, head injury, acute alcohol or drug intoxication. We have an actual mental problem. These people could have some form of actual disease process that is causing their altered mental status. So we have to pay significant attention to figuring out, is this a disease? Is this a mental disorder? Is this a new problem for this patient? Is this an ongoing problem for this patient? We actually have to do a lot of trying to figure out what exactly is going on here, because it would be easy for us to miss something like a stroke, or something like some profound hypoxia, or something like some hypoperfusion, by just saying, oh, well, we're at Bob's house again and everybody knows Bob's crazy, or we're at Bob's house again and everybody knows Bob's a drunk. That's not enough. We still have to do what we know that we need to do and what we do on every single patient, because the minute we start saying, well, we're at Bob's house again and it's a Friday and Bob's always drunk on Fridays, that's when we miss things like stroke or seizure or head injury or hypoglycemia or hypoxia. We have to go into every single call and every single patient with a clean slate. We can't go in with these preconceived notions that, well, we're, oh yeah, 123 Main Street, we're at Bob's house again. It's a Friday. Bob's just going to be hammered and belligerent. We need to make sure what we're dealing with is actually what we're dealing with by carefully assessing every single patient, and patients that are having behavioral or mental health type issues are absolutely no different. Mental disorders, here's your book definition: an illness with psychological or behavioral symptoms. And these aren't, people that are just walking around and doing things that are grossly out of sorts. This is something as simple as your patient who's anxious or depressed. It's not always the big, scary psychological conditions that will have us interacting with a patient based on their need for mental health assistance. We can have social, psychological, genetic, physical, chemical, biological disturbances that will make a lot of these things worse. Social and psychological are two big ones. With COVID going on right now, there has been such a huge increase in mental health concerns because people are afraid. People are being forced to live outside of what is the social norm. You don't get to go out, you don't get to see people, you don't get to speak to people, you don't get to hang out with friends, you don't get to see your family as often. And it's pretty simple to see how things of that nature can aggravate some of these conditions that we're going to talk about and really pose and present to us a pretty significant behavioral type emergency for our patient. Here are some of the reasons that training in these behavioral health type classes and type issues and type emergencies is beneficial to us. That's something that, especially as we start dealing with, experienced providers some of the times in continuing education classes, a lot of the times people want to know, why is this beneficial to me? Well, let's start with the fact that it creates a safer work environment for us. if we are well versed in some of the de-escalation techniques and some of the ways and what fors as to how to not make a situation worse with a behavioral emergency, then it stands to reason that a patient, someone who's in a behavioral crisis or a psychological crisis, is going to be much less likely to lash out and act out at us as EMS providers. These types of things make us better communicators, and not just better communicators with people who are having a behavioral issue. These make us better communicators with everyone. It makes us a better communicator in our personal life. It makes us a better communicator in our professional life. And it makes us better able to talk and deal with people that are having a behavioral emergency. Getting right down to brass tacks, it's going to save more lives. If people are under the impression that they are going to be treated poorly when the ambulance shows up and they're in a behavioral crisis, they are less likely to reach out for help. And in being less likely to reach out for help means they are more likely to drastically solve a temporary problem permanently. It makes us better at helping people. Period. At the end of it, it makes us better at helping people. And being better at helping people will actually provide some psychological and physiological beneficial effects to us. You know, everybody thinks about, you know, the calls that didn't go great. And it's easy to beat yourself up for a call that had a negative outcome, that was going to have a negative outcome no matter what you did. But it's very easy to look back and think, well, I didn't save that one, and I didn't save this one, and what if I had been better, and what if I had been smarter, and what if I had been faster? But as much as I'm a pragmatist, I'm definitely someone who can see the glass is a little more half full, because I know no matter how good I am as an EMT, no matter how good I train you guys all to be, you can't help everyone. It's just impossible. But if you can think back to someone that you assisted, that you had a profound positive impact on, and you were able to provide them really good, high quality care, in and of itself, that will make you feel better psychologically, that will make you feel better professionally, and feeling better and thinking better about yourself will give you some personal benefit. So let's get knee deep into this. Physical or organic problems are permanent dysfunctions to the brain caused by things like head injury, tumor, stroke. A lot of the times we'll see behavioral crises in people that, or behavioral changes in things that have had, not things, people that have had things like stroke or a head trauma or persistent drug abuse. Hypo and hyperthermia can actually make the brain dysfunction a little bit and cause some behavioral issues. Your hypoglycemia patient, their brain is just popping off all around, and they are capable of just absolutely well out of sort behavioral type problems. Hypoxia, same thing. Patient whose brain is not getting enough oxygen is not going to function well, and we will see a physical or organic cause to their altered mental status. These are all the things that we need to look at ahead of time before we just talk about a behavioral issue as a strictly behavioral issue. We have to make sure that our patient's blood sugar isn't low, their oxygen saturation isn't low, and their respiratory rate, rhythm, and quality is still adequate to maintain them as a person. We need to make sure that they're not having a stroke. We need to rule out things like head trauma. Hey, have you had a fall recently? Did you get hit in the head with anything? We also take a quick peek at mind-altering substances, so drugs and alcohol. Hypo and hyperthermia, pretty easy. Is my patient really, really cold, or is my patient really, really hot? We want to make sure we look everywhere under the hood before we just decide that our behavior issue has a psychological component. This is a disorder where we have abnormal operation of the brain. There's no real change in the structure, physiology, nothing like that, but something is not functioning appropriately, and the brain itself is not handling those issues well. Obviously, our psychological, functional, behavioral issues are going to be things like depression and schizophrenia and delirium. Delirium could be organic as well. You see in that, inside the parentheses there. Delirium is something that can be caused also by alcohol withdrawal. So there's another thing to check off of our list. If we know that we go to Bob's house 6 nights out of 7 and Bob is fall down drunk, and then for a week we don't hear from Bob because Bob has stopped drinking. By the time we get to 6 days out of 7, Bob could be seeing things and hearing things that you can't convince him aren't really there, because the body has become so dependent on alcohol as a substance in the body that the brain can't function without it. We have all sorts of dissociative disorders, like your patients who can just be sociopaths and just be completely disassociated with the things that they are doing. Now, we have other conduct disorders. Dementia can be part of this as well, but Alzheimer's and dementia really kind of go hand in hand. Sometimes dementia doesn't really present as organically. It presents more as a psychological issue and can be treated as such. A lot of these psychological type issues can be managed. Psychological problems can be not cured, but helped, and a little bit of healing process can take place with sometimes just something as simple as talk therapy. Some of these others will require medication. So, depression. It is got a book definition as well: a persistent mood of sadness, despair, or discouragement. This is not your patient who just had something terrible happen in their life and is really, really sad. Someone who is clinically depressed is someone who that feeling of sadness never goes away. That feeling of sadness never gets any better. They feel like nothing is ever going to improve. Depression can be both a sign, a symptom, or a disease all on its own. But it is really just overall feeling of sadness. Your patient will complain of some lack of energy. They may have poor eating habits and poor sleeping habits. They feel helpless and hopeless. And they might have suicidal ideations. What's a suicidal ideation?
When you want to commit suicide, but you won't do it necessarily, but you are thinking about it.
Yeah, you're thinking about it, you want to, but you don't really have always a plan. When somebody tells you that they're going to commit suicide and then lays out for you a very well-developed, well-thought-out, logical plan, that is someone who has spent a great deal of time thinking about this, and they mean business. Anytime somebody has a suicidal ideation, that is clinically significant in my book. Some of the things that we think about when we're going to talk depression is a lot of the times when our depression patient has those suicidal ideations and comes up with their plan and decides that they're going to do it, they might pick a day, they might pick a time, they might know just when, where, and how. Then they start to feel better. They're no longer that hopeless and helpless, because they know that a week from Tuesday, they're going to help themselves. And they don't have to be hopeless anymore, because all of it's going to go away. They may actually start having more energy. They may not be as sad anymore. They may start really going out and enjoying themselves, because they know a week from Tuesday, I don't have to deal with any of this garbage anymore. That is a patient who, as far as depression and suicidal ideation goes, is about as sick as they can be.
Do you think it's more common for men to commit suicide out of nowhere, I feel like, than women, because men are, like, not to stereotype, but men are more apt to not express their feelings. So would you say that is true?
Yeah, well, if you look at the numbers, and sometimes they're skewed because this isn't something that people like to talk about or like to report, but women will generally make more attempts. Men are successful more often.
Right. Yeah, men usually are successful. They're not gonna they're just gonna do it and instead of just or
Well,
not
and
telling anybody.
if you look at the means that most men will use to kill themselves, it's typically a lot more aggressive. It goes along a lot more along the lines of like alpha personality type stuff.
There's not a lot of coming back from chewing on a gun barrel.
Yeah, I'm glad somebody said it because it's one of those things like men typically choose to go out with a bang, and it's one of those things that it's just the things that men do most of the time prove to be just wholly unsurvivable.
Like even hangings and stuff, those are like pretty
Well,
fast, right?
from what I've seen and from what I've heard and what I've actually responded to, women tend to do things a lot less messy. They'll use medications and stuff like that, something that it's a little bit easier to come back from or to treat. Men will generally hang themselves, drive off a cliff, use a gun. Unless I'm wrong, Tommy.
No, it's not even so much easier to come back from, because most of the time, if somebody's making an attempt, that's not really the end goal. What it really has a lot to do with is to not really, and I don't want this, I'm trying to sputter my way through this without sounding like a jerk. Men a lot of times will not care about sort of body condition after the fact. Like Paul said, you chew on a gun barrel, it's going to blow chunks and pieces all over the place. And women more often than not don't want that dramatic of an effect for the people they're leaving behind.
Yeah.
So the instant gratification for a man is knowing that this problem will not be mine. But women don't really think along that same line, just through years of um, just the way the world is. Men, on the other hand, are really a lot quicker on well, I need to just solve this problem. My wife gets mad at me all the time for that. Like, oh, you have a problem? Solution. Like, here it is. And sometimes the solution isn't what's necessary. It's more along the, like, we need to just end the problem. And in situations where we're talking suicide, so all right, fine. I know plenty of things that I can make this problem stop in the next muscle twitch, but it creates more problems downstream.
Right.
And the difference in brain chemistry all by itself is really the reason that that's not sort of the way this goes with women a lot of the times. And it's not to say that women who make suicide attempts by pills or whatever don't mean it and are always wicked happy when they're saved, because they're not. I can assure you of this. It's just it's more along the lines of just how people are wired.
Right. So when we go to a suicide scene, someone and says they found someone wherever, I don't know, in their home or like, is that considered a crime scene even though it's like they're dead? Like, who goes in first? Would we still go in first even if we're there first? How does that work?
That's another a little from column A, a little from column B type scenario. Just because it's a crime scene, if we think there's a viable patient in there, does not mean we cannot go in.
Mm-hmm.
But we have to start asking ourselves, is the scene safe? Should I go in? We have to try and disrupt that crime scene as little as possible. There's actually almost an entire chapter later in the book about how to work in a crime scene. But yeah, if you think there's a viable patient in there and you think the scene is safe enough to enter, you can enter. There's nothing keeping you out.
But
Because
like,
it is a crime scene, especially if there is like legitimate dead person in that room.
yeah,
It still goes down as an unknown, uninvestigated death, and it will be investigated.
right. But like, if you like, what something that really registered with me when we first day was when, or the second day, I'm not sure which day, but I forget the man that came in. He works for the other part of the Cataldo,
Okay, yep.
the older guy, and he said that he walked into a suicide in like after the dad killed the three kids, and I was just wondering what happened. Why did he go in to that scene first if he knew that, like, did he already know that everybody was dead, like, or did he really think, did he, I don't know.
No, there could be plenty of reason. Rob's really a ray of sunshine sometimes, isn't he? Oof.
Well, I
Um,
mean, I thought it was a good thing to present to us too, because you're gonna see things like that. Um, but I just was thinking, like, do you go in, like, how, is it within my scope to go into something like that when I know that someone found them and that, it's such a terrible scene, and I know that as an EMT you're gonna see terrible things, but that's something that he said that he had to, like, really, got taken back by, and went on his boat after, and, like, he couldn't really deal with that situation. So if you can, like, prevent something for your own mental health too, like, is that, it's just it's a tough situation. Like, if you know they're all dead, like, do you go in and put yourself through that kind of pain? But I don't know.
no, and you're right, because we can spend the last few minutes here actually talking about mental health as providers, because you are going to see some pretty ruddy, nasty stuff and things that normal people don't see, and normal people don't put themselves in position to be involved in some of the stuff that we're going to be involved in.
Right.
And Rob did really bring that to the forefront very quickly in your second day of EMT class. And there's no real way to sort of protect yourself from the initial trauma of a nasty scene,
Yeah.
because really we're pot committed. We are tasked with going into that.
Right.
It's going to be a lot of the management things that you employ afterwards that will protect your mental health. So when we talked in chapter 2 about well-being and how to manage your own stress, and it's right up there on the screen, how to manage your own anxiety and your own feelings, and how to keep things sort of in perspective and in check. I'm sure Rob went into that scene much the same way I would have, hoping to find somebody still workable, still salvageable.
Right.
Because you get dispatched for, report of multiple shots fired in a residential home. You start running through the list of things of what this could be, and none of them are good. But you hope that there's something good that can come out of it. Maybe I can save one.
Right.
Maybe, rather than killing the whole family, the father just lit off the first shot so that everybody would get out and somebody would call for help, and then lit off the second one to do the job.
Right.
You know, you start playing it in your head. All right, well, you know, this is not a normal people don't do this. So hopefully when I get there, it's not as awful as I feel like it's going to be. And then you walk in and it's awful.
Mhm.
But managing your own will make you better at helping people that are in a behavioral crisis of their own. And we're not, as providers, we're not real good at that. People still in this field view having, you know, problems with PTSD and stress from the job and just recurrent issues from being depressed to being anxious to having nightmares and such from things that you've seen and stuff that you've been involved in as weakness. People still, to this day, are like, oh, well, they can't hack it. Nobody can hack some of this stuff. Are you kidding me? If
Right.
you don't have some decent ways of dealing and coping with these things that you're going to be involved in, this job eats people alive. That's why a lot of the EMTs and paramedics that you see sort of tromping around that have been at it for 20, 25, 30 years are all miserable, crusty old coots.
I
Because,
feel like back 20 years ago when they were started to work, like even like in the 80s and 90s, like they didn't have the same help as today people do today, and they didn't really talk about mental health as much now. Like
back
now,
then
they
it
do.
was back then it was suck it up, cupcake.
Yeah.
And I'll tell you, that mentality has led me to a lot of funerals, and I skip them now.
I think it's okay to be tough, but like you still like have to talk about it. It's like no
Right.
one's like a superhuman, you know?
Tough in the moment is what gets us through the moment,
Right.
but tough doesn't last forever. The bigger they are, the harder they fall. Tough is something that will want. I mean, why do you think the alcohol and drug abuse and divorce rates in the public safety fields are so high?
Hey,
Yeah,
Tommy, I know what you're saying about the funerals. When I was at the prison, we averaged 3 a year of bringing the dress uniform out and putting the band on the badge.
Yeah, never
Minimum
again.
3
I'll
a
never
year.
go to another one.
The last one I went to was a kid that I actually helped him get the job, and I went to high school with him. And I vowed at that point I'll never go to another one.
Yep. I'm not doing it anymore because I am one of those people that you can reach out to in the middle of the night. I mean, I know a kid who jumped off the Tobin, and I'll tell you, it's effective. But he was someone that on a regular basis I would hang out with, I would go out with. I knew his friends, I knew his family. Um, and sometimes all of this stuff just becomes a bit too much, and people drastically solve temporary problems with permanent solutions rather than doing the work. Do the legwork. If you feel like something is starting to add up and bother you, pick up the phone and call somebody. 24 hours a day, you can call and get help. If we're available 24 hours a day to help other people, we should be available 24 hours a day to help ourselves.
All right.
And that really is the long and short of it. But everybody still has that same mentality. I'm 10 foot tall and bulletproof. And nobody wants to ask for it. Everybody knows it's available. I talk about it in continuing education classes. I talk about it in lectures. We're doing it right now. I talk about it in refresher classes. I talk to police, fire, and EMS people about it because I'm sick of reading about our people in the newspaper. But until we switch and really learn to look after ourselves and look after each other as good as we do our patients, the cycle just continues. So there needs to be a switch in mentality because I will tell you, there is buy-in at the top for this because the people that run police departments and fire departments and Dennis Cataldo doesn't want to hear about his EMTs going off the rails and hanging themselves in a public place or doing any of the sort, jumping off the Tobin, suck starting a shotgun. Like this is not good things that public safety people are doing to themselves. So nobody wants it to continue, but this is one of those times where we have to have buy-in from the boots on the ground, the rank and file. And until that whole mentality switches and people decide that it doesn't make you a wuss for saying, you know what, this is just too much for me. I need a breather. I need to talk to somebody. I need to go through some of that critical incident stress debriefing. I need to talk to some of these professionals whose job it is to get me through and have me come out the other side the same person that I was and continue being able to help people because that's what I want to do. We're going to wind up with the same problems. You know, you can't bang your head against the wall and complain about the wall giving you a headache. And I just soapboxed us right to 11:30. That's great. Well, I hope that was helpful.
No, absolutely. I mean, I just think it's important to talk about, what we're going to see and how we're going to deal with it, because I do sometimes think to myself, like, I feel like I'm crazy going into this profession, but it's like I still want to, even though.
All right, let me put your mind at ease here a little bit. You are. And the other thing is, most of our days are spent in abject boredom. 95% of our day is sitting around, or even when we're moving people, still 95% of our day is routine.
Yep.
It's that 5% that, somebody's really sick, somebody's really injured, something really bad happened, I'm working a cardiac arrest. It's that 5% that is where we get ourselves into a pinch. And it's hard then to go from that 5% back to the 95%, back to the mundane, and still sort of continue on down the road.
Right.
So keep doing the same things you do now after you get this job. Keep the same sort of things that make you happy and give joy to your life as a person. Don't let an EMT become what you are. It's what you do for a living. Doesn't matter if you're a firefighter, a cop, an EMT, a paramedic. I would say the same thing to all of them. I've been in most of their shoes. It's not who you are, it's what you do. So the minute this job starts to take over who you are and make your life miserable and make you argue and fuss and fight with your family and make your life less enjoyable, go find another one. Because they don't pay us enough for that crap. Oh boy, now I've really done it. All right, you guys are
Sorry,
all
I
set.
keep talking.
No, that's okay. We can talk more when you guys get in. I'll see everybody at 1. It's 11:30 now, so I'll see you in a little bit, and we'll get through some case studies and some things like that, and we'll see where the day takes us. It's going to be just me again because, well, it's a Friday. And I'll see you guys all soon.
All right, thank you.
You got it.
Thank you.